for joining us today. Welcome to our third Leong Center Trainee Hub webinar. Today's event is titled Community-Based Research, Preparing Your Study for REB Submission. I am incredibly delighted to introduce our guest speaker today, Maria Isabel Suarez, for today's event. Maria has been working as a research ethics coordinator for the Sick Kids Research Ethics and Regulatory Compliance Office since 2015. And before this, she worked for several years as an REB coordinator at a major downtown hospital and a community hospital. She also has several years' experience as a clinical research coordinator for HIV and oncology clinical drug trials and qualitative studies in adult diabetes. She's a foreign-trained healthcare professional with experience in the care of adult and pediatric populations in community settings. She received her master's degree in public health from the Johns Hopkins University Bloomberg School of Public Health. She spends her spare time working in the community with older adults and has done volunteer work with immigrants and refugees and people with HIV/AIDS. Maria is also actively involved in conducting education sessions for the Sick Kids research community. She also does pre and post submission consultations for study teams to help facilitate REB review and approval. So thank you so much, Maria, for joining us today. Again, I can't tell you how excited I am and how long I've been waiting for this particular session so that we can really talk a bit more about the REB submission process as it relates to community-based research projects. Yes. I'm now going to hand it over to you.
Okay, thank you, Priscilla, and welcome everybody. I just wanted to let you know that since we're a small group, perhaps we can, depending on the question, perhaps we can actually interrupt if you the session. If you have a question, Priscilla, if you could please help me monitor the chat group because I can't see it because I'm sharing my screen. Anyway, I'm so sorry I can't share my. You can't see me because my camera's not working. And so today we're going to be talking about community-based research and preparing your study for REB submission. Oops, sorry. So as part of the clinical research services, we actually created a clinical research competency framework with core domains. And this is basically, it was developed to define the knowledge, skills, and attitudes that are essential for effective, ethical, and safe conduct of research studies done at sick kids. And this education session, if you refer to the diagram, it would fall under domain 2, which would be ethical and participant safety considerations in the conduct of a clinical study. So when we refer to clinical studies, we refer to basically not just clinical drug trials, but any research study conducted at sick kids. So you're welcome to look at this. It's available online. If you search clinical research competency framework under the CRS website, you'll find more detail about this. So we have a lot of topics to cover, like definition of terms, ethics and privacy issues involving research in children, as well as ethics and privacy issues you need to consider when you design and submit your study. We're going to touch briefly on sick kids institutional policies and processes related to research. Mandatory retraining required for study teams conducting research as sick kids. Safety for research participants and study team members, especially if you're working in the community. Important tools and resources. We'll go at the end towards the REB's review and approval process as sick kids. How to prepare your REB application, what documents to submit, how to complete the electronic REB application, and common errors that need to be avoided to facilitate the review and approval of your REB application. So the first definition we'll be talking about is because what is community? So essentially, community is different things. It could be a physical place where people connect. It could be a virtual place, especially now with the onslaught of social media. It can be a social media group or a private community platform. The thing is that members in the community have a particular characteristic or interest in common with others, and typically there's a feeling of fellowship with others as a result of shared common interests, experiences, beliefs, or goals. So community-based research, For the purpose of this presentation, I'm just actually going to talk about, I'm going to refer to involvement in the community as anything that's community-based. So it's typically a collaborative or participatory approach to research. It usually starts with a topic of concern that involves the community, and it's conducted in the community so it's important, conducted in the community, with the community, and by the community. And so essentially it's a partnership between kids and youth, typically parents and families, students and faculty doing the study, community-based organizations. These could be nonprofits, this could be patient advocacy groups, this could be any organized group. Healthcare providers that could be within the institution, the hospital, or within the community, policy and other decision makers like politicians, like city councilors, city officials, and then of course the funders who could be industry or not-for-profit. So 5 key attributes of community-based research. It's, like I said, it's community is the unit of identity, and it's typically used as an approach for vulnerable and marginalized populations. Collaboration and partnership should be equal throughout the entire process, ideally, but we'll talk about this more later. And because community-based research is not like traditional biomedical research, the process is it constantly evolves. It's flexible. It's iterative, and things can happen on an emergent basis. And the main thing is the research process is geared toward social action. So key principles would be research should be relevant. It should be equitable, meaning that none should be excluded. I mean, we'll talk about inclusion criteria later and how this could affect ethics of participation. And then of course it's action oriented. It's not just, one of the goals is that there should be mutual benefits to all partners involved, not just the researcher and not just the person conducting the research. So why is community-based research done? Mainly there's a lot of benefits for academic researchers, and of course for the community as a whole. It's more socially relevant and equitable. Creating partnerships with the community members facilitates recruitment. I've seen this happen with a lot of the divisions that I work with, who work with the community. When they have problems with recruitment, they extend recruitment outside of sick kids, and then they're able to get a more wholesome group of participants and increases the validity of the studies. Recognizing the lived experience and multiple realities of participants, again, increases validity of research findings. You don't just limit within an institution. And it's an alternative to top-down methodologies. As you know, now the bottoms-up approach is more acceptable because the people who live the experience, the people who actually have the issues know exactly what the issues are and how problems can be solved. So community members, they're involved as partners. They can be trained, ideally they should be trained as peer researchers to take on a more active role in the research process. And they should be involved in processes of capacity building and empowerment to play a more prominent role. So this is a slide from the patient and family engagement in research at site at SickKids, where they actually incorporate patient and family voices into the development and conduct of research studies at SickKids. They seek to make studies more relevant to patient and family needs, and patients and families who have lived experience are actually involved as partners at all stages of the study, so it helps the study become more valid. So the researchers aim to inform, they consult, they involve, they collaborate, and then at the end, they hope to empower. And it's a continuum, it's a spectrum. It could be fluid, but if you are thinking about doing engagement, please contact Francine Buchanan at the website is on the internet, Patient and Family Engagement and Research, very helpful. So we talk about university and community partnerships. The current challenge for academic institutions is to become more vigorous as a partner in the search for answers to the most pressing social, civic, economic, moral, and of course the health problems. And University and Community Research Alliances is a new method for investigating problems related to health and well-being. They're for social determinants of health and determining innovative or best practices, not just to diagnose, but treat and prevent health issues. So study designs can be varied. They can be qualitative, they can be quantitative, mixed methods. Arts-based methods are becoming more common now. They facilitate expression in the lived experience, things such as a photo voice, digital storytelling, mapping, drawings, creation of collages. So these are just some of the typical, the usual designs that you can use when you do research in the community. So who is the researcher at Sick Kids? This is important. If you're going to be working with Sick Kids, either as a student or a staff, the researcher is anyone who conducts a research study at or under the auspices of SICKIDS. So this can involve individuals with scientific appointments at the Research Institute, who are typically the principal investigators and co-investigators. It could involve research nurses and staff and volunteers. If you are a trainee, you can be an undergrad or grad student, postdoc fellow, clinical fellows, and house staff and other students as defined by the Hospitals for Sick Children bylaws, Part 2, Article 12. So if you want to know more about this, you can search this on the internet. So if you are a student, you need a supervisor. This is the individual to whom you will be formally reporting to as part of your research undertaking at Sick Kids. Trainees and research staff need to report to an individual who has a scientific appointment in the Sick Kids Research Institute, or is a Sick Kids medical, dental, nursing, or professional staff. So this is required. If you're a student, you need someone to supervise you. And this is different from your faculty supervisor at the university or college you're attending. So Sick Kids policies and guidance documents, we have a lot, quite a bit. It is very good for you to know these things because they actually help guide you in terms of what you need to do if you are going to be creating your protocol or devising your methods and design. So there's one specific one for research conduct at Sick Kids. It's called Responsible Conduct of Research. What I'll be doing is I'll be creating a SharePoint file and I'll be uploading all these documents so that you can actually access them and you don't have to spend too much time looking for them because I already have them on file. And then, of course, there's clinical research study participant policy. For privacy, there are many. Privacy and confidentiality of information, the PIPEDA, remote access policy, which we'll be talking about later, SICKIDS records creation, retention, destruction policy, the information technology acceptable use, which is has to do more with online platforms, initial privacy analysis, and then of course we have the electronic mail and instant messaging policies and information security. For safety, there's a safety reporting policy. And if you're dealing with biological materials or blood samples or any other samples, there's a safe handling of human specimens in research labs if you're working in a lab, biomedical waste management and disposal as well. And then, of course, for more relevant to student researchers is consent. Free and informed consent in research is actually a policy at SICKIDS. And then, of course, to prevent conflicts of interest and other issues, legal issues, there's relationship disclosure management, and then prohibited fees in recruitment of research subjects or participants. So this is the website. If you want to know more about what policies are available, this is the website. But like I said, I'll try to create a SharePoint file folder so we can have all these documents in place. Now, in terms of mandatory training for SICKIDS research staff, all people, all researchers, students included, are required to do the TCPS2 core training. Just to let you know, if you've worked with TCPS before, it has been updated in 2022, and the course on research ethics is available online. There's a training on research. We just discussed the SICKIDS research policies, which you need to go through. ICH GCP Guidance E6. And then there's another one. This is mandatory, the CITI Canada Online Educational Program. The link is on the website below. Depending on your role, if you're dealing with clinical drug trials or individual studies or device studies, you need to know N2 standard operating policies and, of course, the Health Canada regulatory training session. Now we go to the core ethical principles. If there are any no more questions. Okay, so researchers, regardless of what type of study you do, need to uphold core principles. There are 3 core ethical principles: respect for persons, which is the right to self-determination through free, informed, and ongoing consent. So what that means is that it's not sufficient that you have a document that people sign. There's supposed to be a process by which you explain this study to the participant, potential participant, answer their questions, and then allow them the time to think about it. Nothing except if you're dealing with a clinical drug trial where it's a last end of the line treatment and there's no other options. Typically, you have time to do a proper informed consent process. This is why when you're as a student, you should actually think about your timelines. Okay. Consent for welfare essentially simply means do no harm. You minimize the risks, harms, and inconveniences, and you try to maximize the benefits, or at least try to balance them so that uh, you're not putting people at undue risk. Justice is the obligation to actually treat persons fairly and equitably. Inclusion criteria should be justified by the research question and should not be done to purposely exclude individuals just to make things easy for you, you know. And then of course you have to avoid coercion depending on your role. Like, you know, if you're in clinical roles, sometimes you wear two hats. You're a researcher and you're also part of circle of care. You try to avoid the coercion. You can be involved in the consent process, but you cannot be involved in signatures. And of course, like again, it's we want to mitigate the impression or the perception of undue influence. If you're in a position of power, like say for example, your teacher wants to do a study on students in his class, it could, you know, you're going to be fearful for your grade. You're going to be fearful for your class standing and how your teacher will be treating you. We want the same thing. And when we're doing research in whatever situation or setting, we want to avoid undue influence and the perception of coercion. So principles of ethical conduct and protection of research participants, there are actually several. You know, this is different from the core ethical principles. These are for the protection of participants. You have to be scientifically valid. It's useless to actually recruit participants, have them go through a lot of things, but your findings are not valid. It's kind of like a waste of time. Fair subject selection, we've already talked about it. You have to be equitable. You have to not exclude people just because it's easier for you not to include them. Independent review. Science reviews are actually we try to encourage that you pick people who have expertise and who actually are not involved with the study. You don't want conflict of interest. Again, favorable risk-benefit ratio to minimize harms. Informed consent. We want informed consent, like I mentioned. It's part of a core ethical principle of respect for participants. Okay. So just to give you a brief timeline of research and what happened, this is just an example. I used this slide for a presentation on vulnerable populations. And you can, as early as even before the Nuremberg Code, Canada was already involved in the Canadian TB vaccine study, where they actually tried to elucidate the TB, the process of developing an immunity in tuberculosis in children, and they tested children using the BCG vaccine without actually consenting them. Of course, you already know about the Tuskegee syphilis study. Who doesn't know about it? And the Nazi experiments. The human radiation experiment was kind of like something that they, during the Cold World War, the Second World War, what happened was they were working with nuclear substances, and because they wanted to create a safe environment for their staff, they decided to do a study which was top secret, and they started injecting plutonium and other radioactive substances into unsuspecting, unconsented patients who were enrolled from like hospital settings, like someone who has cancer, people who had undetermined diagnosis. And then what they did was they injected them with this, they followed them up. Follow-up was intensive and a lot of times invasive. They actually had one guy where they had to do surgeries to take tumors out because they developed them, take out all their teeth and all that stuff. And so it's just kind of like, you know, scary. And then of course, you know, the Jewish chronic disease hospital study, where they studied people admitted to the hospital. We have the Willbrook study where they actually tried to elucidate, again, hepatitis A and B. They actually ended up coming up with vaccines. And then of course the San Antonio contraceptive study, where they enrolled women unknowingly into 4 groups, one of which was placebo. They were actually women who went to a clinic. to obtain contraception to prevent pregnancy. And they, without telling these people, they just tested different types of contraceptive methods, trying to find out side effects and effectivity and efficacy. And one particular group didn't get anything at all. So, you know, it's just kind of like scary. And of course, as a result of these, all those things listed at the bottom are on the right side, which are the guidance documents and milestones came up. We have the Food and Drug Cosmetic, but these the Declaration of Health, Helsinki, Belmont Report, Human Rights Act, Freedom of Information Act, Mental Health Capacity, GDPR, and Data Protection Act, and a lot of other things in Canada. So research ethics review for community-based research studies. These studies do not actually fit well within traditional research models that REBs typically review. So there's a need to distinguish the roles of community partners. Are they researchers or are they participants? When you submit something to the REB, it has to be clear in your protocol. Are they researchers or are they participants? Methods are different from biomedical research. You will see later on if you've ever done any courses on qualitative community-based research, or if you've ever been participating in any biomedical research, you'll find that community-based research methods are actually quite different. And of course, because they're different, the risks related to these methods are unique. They're not quote unquote simple as those we see in observational and interventional studies. Typically, interventional studies, they do animal studies, right? And they're able to tell you that, okay, these are the expected findings, adverse events that can occur. But in community-based research, because of the methods, we cannot basically predict most of the risks, or there's difficulty in its evaluating risks. But still, regardless of whatever type of study you're doing, the minimum requirements should be based on core ethical principles: respect for person, concern for welfare, and justice. So ethical issues unique to CBR. We just need to talk about this for a minute because it's going to help you and it's going to help us at the REB when you submit studies for review. There's a need to ensure that there's a balance between community values, needs, and identity with those of the individuals. So typically when you do community-based research or you do community engagement, there's an individual, there's a community, you have to balance their needs. There are multiple stakeholders, which may entail negotiating power and dynamics in relationships. So if you're a student researcher, you have your faculty advisor, you have to you have stakeholders in the community, like, you know, the members or the heads of the community organizations or patient advocacy groups that you work with. And of course, you have the patients and their families who have different expectations. So there are potentially conflicting ethical requirements and expectations from multiple REBs reviewing the study. So because you are involved if you're a student, you're affiliated with SICKIDS, then you essentially have at least 2 REBs reviewing this. If you are a multi-site your research involves multiple sites as collaborators, then the more REBs are required to review this. And sometimes it could be potentially conflicting reviews. And of course, there's this unspoken duty on the part of the research to facilitate social action emerging from researchers. You're already working, a lot of the times when you work with the community, they are stigmatized populations. And a lack of awareness and critical reflection of the ethical considerations can perpetuate the same problems that the study seeks to address. You can actually unknowingly increase inequality, oppression, or marginalization. So, the focus on individual ethics has actually left some communities vulnerable to risks. Research being done with academic collaborations are usually done to advance. I'm sorry to say this, but a lot of it is done to advance academic careers, sometimes at the expense of communities. Wasting resources by selecting community. When you do not select your community properly, you're wasting resources and using inappropriate methodologies. There are some communities, like say, for example, the HIV community, they may feel over-researched or coerced or even misled. Researchers can stigmatize communities by releasing sensitive data. We'll talk about data later, and without prior consultation. So the consent process as SICKIDS, the consent form templates actually define what is how you can collect data, what's sensitive data, what you can share, how you can share this, and how you can store or use them for future studies. And then, of course, back to the vulnerabilities, communities feel further marginalized by research. Like, say, for example, by identifying them as this group, sometimes you actually increase that sense of marginalization. And then, of course, there's something called the hospital helicopter research. Um, this is when researchers descend on a community. Like, say, for example, you go to a third world country and you go to a community, you do your research, traditional research, but then you leave and you do not give back. The researchers do not often give back. A lot of them, things are better right now. A lot of the global child health studies that I've looked at, they actually seek to give back to the community, improve processes for health. But a lot of the times, the findings are not even shared with the community members. So they may be shared with stakeholders, the heads of departments or divisions, but not with the community members themselves. So they don't know what happened. So what do we want to avoid doing this. It's like you just descend and you leave, but community-based research, technically you should be able to build capacity within communities and improve health and well-being in these communities. So legislations that inform ethics, research ethics, and privacy review. One of the main things is that when we look at your studies is the Ontario Personal Health Information and Protection Act. Section 44 particularly is a relatively new section for disclosure of health information for research purposes. We'll talk about the Ontario Healthcare Consent Act in detail, who can consent and who cannot. Of course, if you're dealing with US studies, you need to know about the US Federal Policy for Protection of Human Subjects. It's also a good reference for Canadian studies, particularly the Common Rule. If you're dealing with sponsors or funders from the Europe, you may need to know the European. There's specific wording in our consent forms for sharing with the European Union and the GDPR. And of course, one of the things too is the not too popular, not too well known, but we're dealing with children in research, so we need to know the UN Convention of the Rights of the Child, which was actually ratified by Canada in 1991. Now, Canada's specific guidance documents, Tri-Council policy statement. Like I said, you are required to do this training if you're ever going to need to go to do research. The training is online, it's free. There's also the ICH Good Clinical Practice or GCP Consolidated Guideline E6. This is more for clinical drug studies. And of course, if you're dealing with a new drug or device or a natural health product, you're testing a health product, then you need to know Health Canada regulations. We use these regulations to actually inform the reviews that we do at the REB. So we're talking about children. A lot of the participants will be children, will be involving youth. So we need to know that research consent in a child is unique. As per the ethical core principle, it should be given voluntarily. But because of their children, there's a potential for undue influence and coercion from persons of authority, the teachers, parents, the healthcare providers, the kids. It should be informed. But how do we present information to children so that they can actually make a decision based on their cognitive developmental capacity? If you work in health sciences, you'll know, or in psychology, you'll know about the cognitive stages of development and it would be good to, when you're doing your consent forms, you use this this knowledge to actually help with your consent form development. Consent shall be an ongoing process. As you know, children develop from no capacity at all, and they slowly, depending on their health and cognitive capacities, they can gain capacity over time, especially if you're doing like research studies that are longitudinal or last for more than 1 year. It's possible that children can actually become able to consent for themselves. So a capacity assessment should be done over time. And of course, consent should precede collection or access of data. Currently, most of the time we'll use written consent, but there are other ways that we will take a look at them and as to how we can actually indicate consent or not. A child can actually indicate consent or non-consent to be part of a study. So specifically for children, these legislations guide consent. Like I said, I mentioned earlier, the UN Convention on the Rights of the Child, respect for views of the child, freedom of expression, freedom of thought, conscience, and religion, right to privacy. This is important. Access to information about your health and well-being. When you collect research data for your research study, they should be able to have access to what you've collected about them. And of course, they need to know that their rights are. If you look at the consent form, we try to address most of this. The consent process at Kids for Children, we try to address most of this. Of course, the Healthcare Consent Act, which I mentioned earlier, you need to know that consent, unlike US and other countries, the US and other countries, consent in Ontario is not age-based. Rather, it is capacity-based. There is no minimum age. You don't have to be 16 to be able to consent to be part of the study. You don't have to be 18. If you're 12 and you can understand the study, then you can determine whether you can be part of that study or not. It's your choice. This is why if you look at our templates, we have a parent consent for the participant, a participant consent specifically for the child who has capacity to be able to understand the study and determine whether they want to be part of that study or not. Like I said, no minimal age. Children who have been assessed for capacity should be allowed to consent for themselves. But then, of course, like we mentioned earlier, it's unique. They have to consider relationships in the family, like, parents. Are they going to give them the ability to decide whether they want to be part of a study or not? Capacity, though, has to be assessed by a regulated healthcare professional. Even if you're doing the study yourself, you cannot do this unless you're a regulated healthcare professional, like a physician, nurse, dentist, anything who is part of a regulated body or college. The reason why this is required is because it's part of their training to actually consent people, and they should know. And the process is actually if you look at the consent form, you can actually you find out what needs to be done during the informed consent process, what things you actually have to tell the potential participants so that they can have an informed consent. But this is the Healthcare Consent Act, so we have to follow this rule. So when you're going through your application and you see capacity, you are working with youth with and without capacity, there's a question specifically on the application that deals with capacity assessment. Use this information to answer that question. So the consent process, again, there's a child. When you look at a child or you look talking to a youth participant, do they have capacity to consent as assessed? Like assessment can be done if the child is being seen as sick kids, you can actually refer to their medical records based on a waiver of consent to check if they have capacity. Then you can actually determine whether they can consent or not. You can use the medical assessment for capacity assessment. So if they have yes, proceed with. If they have capacity, do proceed with the consent process. If no, you can speak with parents, get the parent consent, and required, you have to assent. Remember, concern for respect for person. Just because they're a child and they cannot consent for themselves does not mean that they cannot say no to a study, particularly if it is not involved an intervention that could be life-saving. Say, for example, you just want to do a questionnaire, they don't want to do it, please let them, inform them that they have the ability to say no. Even when they have said yes, when you start your interview or your questionnaire, one of the things we look for is a statement that says, if you change your mind, you can tell the study staff. If you don't want to answer a question, tell the study staff. This is voluntary. You do not need to answer a question if you do not want to. Okay. So obtaining consent for research purposes, it used to be, traditionally it's in writing. We have the templates. The verbal consent form, which is only applicable to certain things. If verbal consent is only applicable if you have only one encounter. Like say, for example, you want to do a study where you have one questionnaire, like say you're doing among a group of community members, like a meeting or a patient advocacy group. You're there, you tell them this is what it, explain to them the consent form, you use a template, you give them an information letter. If they say yes, then you can proceed. Implied consent is like mostly for surveys. Like, implied consent is like by doing the procedure, you are agreeing to be part of the study. But again, it's limited. Implied consent is limited to a one survey thing. Like say, for example, anonymous survey, you send out recruitment or information letter. You say, we'd like you to complete the survey. This is what it's about. At the end, you'll say, By completing and submitting this survey questionnaire, your answers, you have consented to be part of the study. Or if you're doing an interview, by participating in the interview, you have consented to be part of the interview. Typically, these are used mostly for groups where, like say for example, healthcare professionals, or when time is a constraint. But then we are looking exactly at what you're doing. It's usually it's one procedure, one time only. If you think that you're eligible for implied consent, please talk to your study coordinator. If you have a sorry, my dog. If you should know that you try to find out who your divisional ethics coordinator is, and then try to contact them directly. Or if you don't know, ask.crs, email us, and then they'll triage the email and send it to the coordinator for your division. So remote consent process. This came up because of the COVID-19 pandemic. So what this is actually, you're now allowed to do verbal consent discussion by phone or online. So one of the things you have to remember is that it's a participant or parent choice. You cannot insist on it. Otherwise, you have to put in your protocol that consent should be online, or yeah. So online consent means you ensure the participant, but you have to make sure before you do anything that's others outside of traditional ways, is that you have to have you do the assessments that are appropriate. Right now, at this moment, the only methods that are actually eligible for that are PHIPAA compliant, meaning they have been approved by the research information technology team, and then they're for based on the protections for any information shared during the consent process. It's only MS Teams or Zoom Healthcare. So Zoom Healthcare is used by healthcare providers, but there's an associated cost. If you want to use Zoom Healthcare, not Zoom by itself, but Zoom specific for healthcare, because it has specific protections. It has a cost. If you want to use Zoom, you have to budget this cost. If you want to use MS Teams, I think an institution provides the application. Again, if you're doing verbal consent, especially if you have audio and video recording capacities, you cannot audio video record without providing a rationale and without obtaining consent. And then, of course, once you have the verbal consent discussion, you have the ability to actually create documents to document written consent using either paper copies. You send them by email or send them with a DocuSign function, or you can use REDCap. But because we have to consider respect for persons, traditional paper options should continue to be offered. So language levels in the consent process. So consent forms, parent for child and child for child with capacity. This is a requirement of the SICID's REB. This is based on the knowledge that we're a multicultural society. People have varying degrees of English language skills and comprehension and cognitive abilities. So consent forms should be actually at the grade 6 reading and comprehension level. This means essentially, if you have a study and you want to be in the grade 6 reading and comprehension level, you think about, if I explain this to my niece or my nephew who's 11 to 12 years old, or a child who's 11 to 12 years old, will they understand it? The assent form, on the other hand, is at the comprehension level of a 6-year-old. Note its comprehension level. They're not expected to be able to read, but you're still supposed to document assent. There's supposed to be a form where you, as the consenting person, the person who's obtaining assent from this child, will sign that they agreed to be part of the study. And this has to be at the comprehension level of the 6-year-old child. So anything, it has to be very, very simple. Tips, use lay terms. There are actually many plain language terms. So I'm actually going to send you in the SharePoint folder. I'm going to give you an example of documents that have plain language terms. When you're using medical terms for the first time, explain them. But if possible, try to use plain language terms. Use short sentences. Like, as academics there's a tendency to actually have long sentences, sometimes to the point of them being one paragraph long. And that's just one sentence. When you want to simplify, use short sentences. Then, of course, refer to the consent and assent form templates on the internet. I apologize in advance, but some of the wording is still a little bit complex. We're still working on the revisions to these documents. And if you really need help, refer to plain language tools online. There's a lot of them. Just search plain language tools. Or even if you say, like SickKids has about SickKids Health, if you try to Google, just say with the way you phrase your sentence, what is an MRI? And typically there will be plain language explanations for these types of procedures. So options for study visits and procedures everything used to be at SickKids. Now you can do remote recruitment and consent, remote study visits by telephone or virtual methods. And one of the options is still in person. If the participant is being seen at SickKids, you can actually, and they're having a clinic visit or scheduled clinic visit, you can actually, there are wait times. You can actually try to take advantage of the wait times and talk to them about study or do study visits and procedures. What is essential when you submit your application or you create your protocol and submit your application, you provide details and submit your associated documents. So considerations for planning remote visits and procedures. Participant consent. If you are doing consent on virtually or remote visit on MS Teams or Zoom Healthcare, you should let them know. You should consider, do they have the skill or experience with the app? A lot of us think that just because everything, especially there's a tendency, because everybody's using it, there's a tendency to actually think that everybody can use it. But a lot of people don't, or they don't want to use it, or they don't. It's very difficult to comprehend sometimes the ways by which you can use MS Teams or Zoom. And of course, are they willing to learn or use the app? Is against patient choice, respect for person, device compatibility. Not everyone, you have to remember, if you're doing remote visits or virtual procedures, not everyone has the latest iPhone or the latest operating system. They might not have iPads. If you're doing questionnaires, so you want to do the questionnaires online, it's very convenient. They don't have to come to visit, but do they have the device? So think about these things when you're planning your study, when you're doing when you're trying to create your design and your procedures. Secure internet connection. We will talk about personal health information, or PHI for short, later. When you're doing virtual study visits, online platforms, personal health information is typically going to be shared. Even if it's a questionnaire, there's still going to be personal health information, and I'll show you why later. Secure internet connection is essential because personal health information is protected by the Personal Health Information Privacy Act. It's a legislation in Ontario. A lot of people don't have secure, it's like still internet, although the plans, the cost of internet providers has significantly gone down. Still, we have to consider where multicultural economic situations vary. Not a lot of people also may want to pay for all of these things. So they go to public Wi-Fi. You know the risks for public Wi-Fi. Anything that you enter can be seen by an authorized third party. And because you're sharing personal information, research information, which is also covered by the Healthcare Consent Act, you are potentially creating a liability. And then internet usage. Again, not everybody has unlimited internet access. Or like, say, for example, they do have internet, but they only have 500 megabytes. Remember those times when, you couldn't, unlimited or 10 gigabyte plans were not available and you only have 500 megabytes. Consider these things when you're planning for remote visits and procedures, especially if you're doing online applications, using online applications. Talk about video conferencing tools and online platforms. Like I said, again, I have to reiterate this. The only HIPAA compliant online platforms allowed by SickKids is MS Teams and Zoom Healthcare. Again, costs are incurred, so you have to plan for this. Privacy, you have to advise participants that even if the platform is encrypted, SickKids cannot guarantee, none of us can guarantee that the privacy of the information is maintained when you're using these means. Again, I have to reiterate, platforms. MS Teams, Zoom has audio and video recording capacity. You should not video or audio record the visit without prior RAB approval. We require justification. Why do you need that person's face? You already know the voice is an identifier. You add the face to it, you basically have that person. Without consent, you cannot Without sufficient justification, you should not video or audio record any visit procedure, even except for interviews, but with consent and with prior REB approval. One thing, you are staff, you have your own personal devices. It's against its policy to use personal devices, especially if recordings are being done. Again, it's a privacy thing. So for university community collaborations, their new strategies expanded reach to marginalized populations. But like, one of the things that I want to reiterate here is that when you plan to do your study, try not to exclude or neglect people. Just try not to assume and extend your research lens beyond individuals and families. You have to have broader consideration, especially now that we have stepped outside the box of traditional research methods. Try to be considerate. And then when you're working with the community, generate new roles and responsibilities, not just for your researchers, but for your participants as well. Now we come to an important thing. This is important. Please pay attention to the next two slides, because this has created a lot of confusion for people who are submitting research studies at SickKids. So personal health information, according to PHIPAA legislation, again, it's a law. It means any identifying information about the individual in oral, remember oral, or recorded form if the information relates to the health of the individual, physical or mental health, history of the individual. So if you're looking at people with, say, HIV or whatever disease you're looking into the community, or mental health conditions, everything you collect basically about the health history is part of PHI and is protected by legislation. It relates to the provision of healthcare to the individual, including the individual providing the care. So when you're creating documents like data collection forms, and you want to say you're doing it at a community-based clinic, you cannot document that doctor's name or the nurse who did that or the person who did the x-ray. That's part of PHIPAA. Plans for care are also they're all about health information. Payments, if you're doing cost analysis and economic analysis, and you want to collect information about income, payments, and eligibility for healthcare, if presence or absence of OHIP, third-party insurance, anything that relates to payment or eligibility for healthcare, eligibility for coverage of healthcare in respect to the individual is, again, personal health information. If you're looking at body part donation, again, it has to do with health. The OHIP number, individual OHIP. So individual health numbers are either the OHIP number, the MRN, or the MRN, or whatever number is associated with the child's health care. So this is protected. It's sacred, because it's like, if you think about it, it's like your license number or once they have that and they have access to the database that contains the information, it opens up everything about you. So you have to protect these numbers. And of course, anything that identifies the individual substitute decision makers. Say, for example, especially it's not just for families, regular families, like, parents or caregivers, but also most especially if you're dealing with children in foster care situations. So this is all personal health information. In contrast, personal information, you'll notice there's some overlaps. Personal information is you actually document the name of the individual. You document the contact information, demographics. So the contact information is address, email, phone numbers, postal code. I forgot to put this here, postal code, okay? Especially full postal code. I will tell you why postal code is unidentified. It's personal information. In rural areas where one house will occupy, or one farm or one large piece of property will occupy the entire postal code. If there's a child there there's a like, say, for example, child with mental disability, cognitive disabilities, or physical disabilities, or cancer, you already know, you just have the postal code, there's only one child. I live in a condo complex, townhouse complex, where there are only two children, both male, both under 15. Everybody else is older than 20. Okay, if you take up by postal code and you are looking at study, it's kind of like crazy to think why people would do that. But we have to think, when we're protecting privacy of participants, we need to think about situations where their privacy could be compromised. Okay, it's like, or if you search for a postal code, just go after this session, go search your postal code. If you live in an apartment complex, everything there, all like anybody who has not deleted their information from the what do you call it? It used to be called a phone book. Now it's online. You'll find everybody there. And if you're trying to find a child, you'll find them just by having the full postal code. So be careful. Demographics. When you combine race, national or ethnic origin, color, religion, age, and marital status, which is a lot of are the common things that we look at for demographics. If you're working with a specific community and you say, okay, this person is 65 years old, single, there's only one person there, you can actually identify this. So for questionnaires, we actually demographic questionnaires, the option to prefer not to answer is typically requested. You should remember, respect for person, whether they want to, unless you say that you have to answer everything, you should give them the option. Other parts of personal information, the personal history, education, if you're working with students, okay? Or the medical history, the criminal employment history. These are all personal information. You should be careful when you're collecting this, and you should make sure that you have the appropriate privacy protections. Again, this is a repetition from the personal health information, but any assigned identifying number or symbol, I think this refers to other than the OHIP or the MRN, so your license number, or your bank account number, right? That's personal information. Personal opinions of views, except this is a little bit confusing. So any personal or opinion or view that is actually collected for research purposes is personal information. And then, of course, any private or confidential correspondence related to the study or not should be considered personal information. They have to be protected. So these are protected under the Canada Privacy Act. Risk of identification. You think, okay, who would take the time to actually do this, and how much time would it actually, and what is the risk? What is the risk? Like when I talk to people about, use of social media and what data they're collecting, and everybody does it. So what's the risk? But if you're dealing with individual level data with broad disclosures of health and other research data, when used in combination with personal identifiers, you increase the risk of relinking that data to a particular person and identifying that person. So you don't want that risk. We actually take a look at that when you in the sections of the application about data collection, we look at these things. What are your protections? How do you de-identify? Where do you store personal information? In particular, you should pay attention to this. When you are doing a study, we will ask you for a master linking log. This is not an approvable document, but it's a log where you can actually put down the participant's name, their contact information, their parents' name if they're without capacity. You can actually put all of these things in the master linking log and have that study ID number there. So again, re-identification, like I said, full partial postal codes, name of the organization, role, and year. Say, for example, if I'm participating and you want to, if I'm, say, for example, a nurse at Sick Kids, you're going to say, my demographics will say nurse at the ICU in service for the last 2 years, female, single, and blah, blah, blah. You can basically, in the ICU, easily identify who I am. Oh, but that's not me, okay? Multi-site research, if you're doing more than one site, we will typically require RAB approvals at affiliated sites. If you're sharing data, study agreements, please, study agreements, they take a lot of time. Please try to actually have these things in place. One of the first things you have to look at when you're doing multi-site research is to actually contact the RCMO, Research Contracts Management Office, to start your agreements. Off-site research, if you're doing global child health research, will typically require ethics committee approval at the country site. Safety and research, here, who's responsible for protecting participant safety? Everyone involved in the study, the investigator, the agencies, the institutional RAB, the research team. So if you're doing research, so we're talking about research safety. If you're doing study visits outside of SICKIDS, say, for example, you have to go to the community, you have to attend the meeting. If you're doing home visits, if you're doing virtual visits, even virtual visits is outside of SICKIDS, you have to provide a detailed safety. You have to identify the risk to yourself. If you're traveling, how can they make sure that you're not How can they make sure that you're safe when you go to this home or this area and you go back home? There's supposed to be a plan. Who will you contact if something happens? Say, for example, you're a TTC and something happens. Who do you contact for safety reasons? You have to have a detailed plan, which should be typically, you can have a written plan. It could be incorporated in your protocol, or it could be a separate one. Use of personal devices is important because the risk extends not only to personal safety, but ethical concerns about boundaries being potentially crossed, especially if you're dealing with youth. You know that right now, you have to be careful what you say. They could be misconstrued as having a relationship or something. You're dealing with young adults and children under 18. You don't want those boundaries to be crossed or like perceived to have been crossed. And so you have, like, when you're using personal devices, you have liabilities, not just to yourself, but for sick kids and the institution or the college that you are affiliated with. So please, if you require devices, either you have to plan to create a special number and get it registered with SickKids Into. They will register and give you a specific SickKids number. When we see numbers that are like 647 or not typically SickKids number, we will ask you, is this a personal device? And then you have to provide the rationale or provide an alternative. Now, participant safety. This is common in a lot of studies I've seen say that, oh, there's no risk for emotional psychological distress. But if you have ever completed a questionnaire interview about extremely personal things to you, like frustration if you're going to med school and you couldn't get into med school, or admitted to the university of your choice, personal relationships, gender identity struggles, history of use of bullying, experience inequities, questions that cause a person to relive unpleasant or traumatic experiences result in emotional or psychological distress. You can essentially re-traumatize them without actually considering. You may not know the extent of participant experiencing distress. Remember, each person has their own way of feeling and thinking about the challenges in their lives. Do not underestimate the effect of an interview or a questionnaire, because you never know. I had one experience where I just did a questionnaire on factors that affect compliance with diabetes medications. We were using a questionnaire. By the end of the questionnaire, the lady was crying and she said to me, I'm going to kill myself tonight. Okay. Now we talk about questionnaires. There are certain questionnaires that don't seem like they're harmful. They're called the BDI-2, PHQ-9, ASQ Toolkit, Suicide Risk Questionnaire. The interview questions include, do you have thoughts of harming yourself? And most importantly, do you have a plan? So when you find these, when you're using these questionnaires, do not underestimate the information. It's the bottom of the questionnaire, okay? Please have a plan. Any response indicating thoughts of self-harm is considered an emergency. And based on privacy laws, confidentiality can be broken to ensure the patient remains safe. So you need to include, if you're using these questionnaires or you're asking about mental health issues, anxiety, depression, you need to have a written safety plan for in-person safety issues. Like if you see them and you see them to distress, what are you going to do? If you're using remote, virtual, or online safe methods, you have to have safety. If they're submitting a questionnaire online, how soon, especially if they're suicidal questionnaires, how soon are you going to actually review these questionnaires and identify that this child or this participant said, I want to kill myself? The plan should include who are you going to contact, what resources are available, and one of the most important things to consider, how do you follow up that person for safety issues? Now, social media use. Social media platforms, as you know, any online or mobile resource that provides a resource, a forum to generate or share, discuss ideas or other content. They can include anything listed here, except now for TikTok. Okay, if you have read SickKids issued messages, TikTok should not advise anymore, but everything else here is still applicable. But you have to consider users are not typically aware of how their public information can be shared. You have to respect community and culture expectations. Individual posts intended for sharing appearances, you should not use this. You should respect user privacy. Even if it's out there, you should respect that. Don't just randomly contact them, because this is like cold calling. Like, you have their phone number, call them, hey, I'm doing a research study. Would you like to be a participant? Guidelines should not involve disruption of any type. Should not have any establish a separate online identity for the purpose of research recruitment. You should not be creeping or lurking social media sites to identify potential participants. Facebook is open, right? They have patient advocacy sites. They have group discussions. It's not proper. It's not ethical to actually lurk. And don't post research recruitment sites on personal page, research recruitment messages on personal pages and accounts, unless you're approved by the CPA, the Communication and Public Affairs Office, and the REB. And if you're establishing a social media site for the purpose of your study, there should be an account login and membership in an online group. If it's an existing group, you should have you should have permission from the administrator to do recruitment. And when you should follow social media platform policies and terms of use. Submitting to the REB, we still require traditional methods, but you need to identify everything that you're using. We will want to see the post, how you're looking at this, how you're responding to it. So advice is to submit your recruitment plan and post to the Communication and Public Affairs Office for review before you submit to us. We may tweak them, but as long as they approve your plan and your post, it's always good. However, if you want to make change, if you want to make them more professional, for a fee, you have to collaborate with Creative Services. So, like I said, I think this is a repeat, sorry. Now about the Research Ethics Board. The board is actually a separate group from the Research Ethics and Regulatory Compliance Office, which is called the REO. So we have a chair, 3 vice chairs, and we have these staff members. There's 2 panels. If your study requires full board review, there's 2 panels for regular studies. High-risk studies, there's panel A and B every 14 of the month, 14 days. But if you're doing AI or machine learning, there's a specific panel for this, and you have to let us know right away. So there's a website. You can know all about the REB on this. Actually, the Research Ethics and Regulatory Compliance Office, which is the REO office, what we do is we support administrative aspects of the research process. We interpret ethics principles and administrative process to help you out, and we do research education outreach to the community. And we're more important, if you're doing a study, you're just starting, please approach your divisional ethics coordinator and request for a pre-submission consult. That way, you can be sure that as you create your documents, you're actually doing them in compliance with what the application and the regulations require. It's online only. If you've never been on the ERB, this is the link. Your username will be your username for Outlook and the same password. Sprint. This is confusing. This is something that is an institutional requirement, but the REB is required to implement. It's essentially a scientific feasibility and operational assessment to make sure that you can do your study safely. It is required for all studies at SICKIS, all your studies regardless of type. If you need when you have your protocol and you have at least your draft documents, please contact Sprint. Here's the contact information, and here's the process. Here's the email. You're going to get a copy of the slides. You can take a look at this. Modules, EREB. It's not intuitive, I promise you. But we have guides. They have visual guides. They are islands. Please feel free to utilize them. If you need help, contact your REB coordinator or go to ask.crs, send an email. How do we determine which studies go to full board? It depends on the risk. If it's more than minimal risk, like drugs, devices, increased population vulnerability, your foster children, indigenous populations, they'll go to full board. Other than that, minimal risk, delegated review. If you're using data that's been collected previously by another researcher, secondary use or secondary samples, then they're also delegated review. Online resources. This is your best friend. Everything you ever need for submitting a research study is on here. Use this link. Go to CRS and select form templates and guidelines. Everything's there. Just click on the blue tab. The menu will show you what you need. Okay. Timelines. As students, you have to be aware of this. I cannot emphasize this. I actually had one consult where, like I was telling Priscilla earlier, he didn't realize that he needed REB approval from SickKids, but all the data was coming from SickKids. So what happened was he had 1 to 2 weeks before the start of his course. He needed approval within 1 to 2 weeks. We got him through it, but please, in order to save yourself stress and to make sure that your documents are in order, please consider these timelines. Sorry, I had to cough there. When you submit a full board study and it's accepted as complete, meaning you have all the essential documents, these are the timelines. Before the review can be initiated and you expect to receive a review letter. So if you have a study that you still want to start by May, you have to start now. You have to do your application, you have to do all your documents, contact your IB coordinator to help you out to see that you can facilitate the review. Plan ahead. Be mindful of your schedule for study initiation, your school timelines, and the REB times that I showed you. And if you're sending data out or you need data from someone else, please initiate the agreements right away. We have a lot of studies which haven't started because of the agreements, because these are two institutions trying to create an agreement which is helpful for both of them. It requires time. Please contact, while you're working with your documents, contact the RCMO, Research Contracts Management Office, and start your agreements. Forms and templates and guidance, again, best friend, here it is. Essential documents, these are the things that you need. Your REB main application is to be completed. Your study protocol, which is different from your proposal. Remember, a proposal is for funding purposes. What the REB needs at Sick Kids is a document that provides us with the justification for why you're doing a study, inclusion, exclusion criteria, how you're going to recruit, how you're going to consent, what data you're going to be collecting, how you're going to analyze this. Essentially, what you can do, my tip to you is use the template, but go for consistency because we have to check the consistency of documents. Your REB main application, there's on the links that I sent you, go to find the annotated forms. You will actually see the questions there. How are you going to recruit? What are your tools? That way you can create your protocol and then you have consistency and you don't have to worry about finding something that's not congruent with what you're saying in one of these documents. Consent and assent forms, we have templates. You just have to plug in certain things based on your study. We have recruitment templates, posters and scripts, they're there. There are scripts for initial and follow-up communications. Data collection forms you have to create yourself. But remember, one of the things that we require for data collection forms is that if you're using validated forms or questionnaires, we need to see them. I think, especially if you're doing them online or creating a red cap version, the study title has to be there because we need to see that it's linked to this particular study. We need a study ID. It has to be linked to a particular person. Version date. Okay, if you're doing it multiple times, we need the timelines or the dates of comparison so that it's not just for us, it's more to facilitate your data collection. But as part of the review process, we have to look at that. Budget and proof of funding. If you have costs, if you're giving out gift cards, if you're traveling, if you're doing meetings and you have any cost at all, have a budget, have a proof of funding. One of the things is that if you're still applying for a proof of funding, you may not be able to receive REB approval, or even at very least, they may not, whoever screening might not accept your application because there's no proof of funding. SFO, this is part of Sprint. There's a form online, you need to complete this form. If you're exempt from science review, which we'll talk about later, it still has to be signed. If they have issues, please submit the responses to prevent delays. Departmental sign-offs, if you use in a different department, you have to seek its service. Like say, for example, you're recruiting from different services. You have to have sign-offs. The Sprint pre-certificate, like again, it's institutional. We have no control over this. Without this, we will send your application back as incomplete. Study agreements, depending on whether you're sending data out or in, and then REB approvals at collaborating sites suggest that you have this so that you prevent delays. So essential documents list, here's your best friend. There is the list. There's information. Just check. Science reviews. It depends on the type of study and the risks. Typically, it's minimum of 1. Expert, or maximum of 3. So they should not be part of your STEAM. If you're thinking of doing this, you will be sent back. Okay, they should not be part of the study team. They should be an expert in your topic of research. They should be a staff member of Sick Kids. If there is no expert at Sick Kids, we will accept external. Trainees, no matter what your level of experience is, there are fellows who are well established in their own fields. They have training and everything, but because they're designated as a trainee at Sick Kids, they're a fellow or they're research associate, they cannot be reviewers for you. Please do not, because this will be sent back. Okay, supporting documents for the SFO review, sprint pre-certificate required. We have no control over this institutional requirement. Peer review, it helps the RAB determine the importance of the research question, especially if it's going to full board. Number of reviewers, interventional studies, anything that has to do with drug device, using a new drug for a new intervention, an approved drug for a new intervention, like metformin for cognitive function, 3 reviewers. Observational studies, like most community-based research are, 2 minimum, preferred 3. Secondary use, 1. Secondary use of data peer reviewed can be waived. Studies that have undergone approved external peer review are exempt, like CIHR, because their review is rigorous. NIH and other agencies. If you think that your study is exempt from the science review based on the funding source, please contact Ask That Service or your divisional coordinator and we'll let you know. Okay. Again, trainees, including fellows, co-investigators, cannot be reviewers. So like I said, exemptions can be granted based on your fund source, your study type, and level of risk. If you think you're eligible for a waiver, contact the REB manager to facilitate the decision. Please provide a copy of your protocol. If you're exempt from the science review, you still have to complete the F and the O part. Feasibility and operational requirement review. This is to ensure that you can do your study. And then divisional departmental head sign off, who should not be part of your study team. So common causes delays. Your documents are incomplete. You lack details. We will be recruiting from this community, period. How? Inconsistent information. You say that your population enrollment is 20, but in your consent form is 40. Differentiating between standard of care and research. If you're altering standard of care in any way, like say, for example, you're looking at children with mental health disabilities and you want to do a questionnaire, is it part of the standard of care? Because we need this information. There's a specific portion of the application which deals with this. How do you, because we need to know what the risks are. It's more for determining what the risks and inconveniences are. Study documents do not follow guidelines or templates. The templates are there. All you have to do is plug and change as you need. And then formatting. Okay, the format is already there also. Please fill in your version dates. Please delete anything that's in blue because those are instructions. So finally, we come to the end. This is how you see us. We delay. We know this is how a lot of people see us. But actually, delays for submissions of studies are no sprint certificate, no science review. Ethics and privacy issues are not addressed appropriately. Format errors, they're minor, but they're for approval purposes. We need to, when we audit, for audit purposes, they have to be appropriate. Also, the templates are meant for a purpose. You have to follow the template, follow the format. Incomplete applications. You forgot your consent form, or you forgot just whatever documents that you need to submit, because we look at the protocol, we look at the application. If there's something missing, depends on how egregious it is. We may return it for you, but it costs you delay. Like, sometimes I will, for students, I will say, okay, can you send to me my email, upload it on your behalf? I just need to see so that I can send out your review. But not everybody does that, and I don't have the opportunity to do that every time. So please make sure what you say and what you do, you have the documents there. Application responses. Please do not okay. Oh, I just need to mention this. The EREB application is not as smart as it is. And what happens is that they have, if you even put a dot on it, it will record as a response. Please do not do that, because if the reviewer sees that and you have a missing, and depending on how many times you do it, it could be returned to you as incomplete. Don't delay yourself. If you think Health Canada is required, please start the process right away. Contact our staff so that your study is not delayed. Now, that was a long one. I'm sorry, but yeah, if you have any questions, please feel free to ask. But a copy of the slides will be sent to you. I'm sorry, I forgot the references section. But like I said, I will be creating a SharePoint file that we can share so that we can actually add the documents that you need on it. and you can access them for your purposes. Okay, any questions?
Thank you so much, Maria. That was
Yeah.
very rich and in-depth in terms of explaining, the intricacies of preparing your study for REB submission. I really appreciated your last visual. I feel like many of us probably have that in mind, that REB offices are gatekeepers, but in fact, we need to, reflect on all those different pieces in their assembly as a whole, and how sometimes we don't necessarily have all the pieces together properly to get that check and ensuring that we're meeting all the requirements. So I appreciate that. It brought a big smile to my face.